it on?
Sure.
All right. Good afternoon, everyone. This is Benilton Carvalho in name of the Brazilian Statistics Association. This is the 11th round of the series of webinars ABE COVID-19, Ações e Desafios. Today we have the great pleasure of having Rafael Irizarry coming here to talk to us about the pandemic and monitoring in general in Puerto Rico, which I just mispronounced. I'm just saying how it is written right now.
It's pronounced Puerto Rico.
Puerto Rico, perfect. So that's how Brazilians would do.
How it's pronounced. All right.
And Rafa, you're good to go. Thank you very much for accepting our invitation.
Thank you.
I'm pretty sure everybody will be very pleased to hear what you have to say.
Thank you. Thanks for the invitations. I'll get right to it. All right, let me click on this. All right, so this is what I hope you take away from this talk. So first, I'm going to tell you how I became involved in this project, if you want to call it that. But the takeaways from what I've learned are written here. One is to beware of sensationalist anecdotes when you're making decisions. I think statisticians, I don't have to tell them that. But then I'm going to make a pitch for using data visualization as the main monitoring strategy for the pandemic, and I think that it's better than the mathematical models, and I'll show you some of that. And then I'll tell you a little bit about the importance of systematic data organization. That's something that has become very clear. It's hard to do, and it's important, and it's very important. Once that's done, the rest is relatively easy. Through this adventure, I've encountered many problems that are the fault of Microsoft Excel. So I will say that that's another takeaway. I might not talk much about that, but if you're using Microsoft Excel to do this, you are not doing it right. So we're going to see a lot of data. We're going to see no formulas. So I just want to warn you, because I know some of you like theory and methods, but that's not what we're talking about today. I'm more telling you a story of how I got involved in some of these things. So, I'll start from the beginning with the Hurricane Maria. I'll tell you a little bit about that too. So I should also warn you, I'm not a COVID-19 expert at all. I'm an applied statistician. I'm the chair and professor of data science at the Dana-Farber Cancer Institute, and my focus is on genomics. That's what I've spent most of my time. But my main interest is really using statistics to solve problems. And genomics, there's just a lot of opportunities to do that. But I have general interest, and this was one of them. And I'll tell you the story of how I got involved with Puerto Rico monitoring first after Hurricane Maria, and then with this COVID pandemic. Okay, so these are the people that I talked to. I want to mention their names because these are actual experts. So one of the things that I recommend applied statisticians to always do is not analyze data on a vacuum. You want to be talking to experts that know things that you might not know, and the data is not always enough. You also need to know how to interpret it and know what hidden biases there could be. So these are three people that work at the Center for Communicable Diseases and Dynamics at Harvard, and they're all great and are always willing to help me understand things better. All right, so I'm going to start by just maybe 10 to 50 minutes telling you the story of how I got involved in helping Puerto Rico with data. So this is 3 years ago. Is it 3 years ago? Yeah. When Hurricane Maria, as you can see in the picture, went right over Puerto Rico. This is what it did to the island. Here's a picture. This is what it did to where I studied. This is where I learned all my math, or was where I learned all my math. So this whole story starts when right after the hurricane. This was about 2 weeks into it. There's a visit of President Trump to Puerto Rico, and there's a quote here of what was the conversation like, and he's celebrating how few people have died, and the governor was no longer the governor, by the way. says it's 16. So that was something that many of us could not believe. My family is all there, and most of my friends are there. The rest are in Brazil. So this was not believable, because we had heard this was anecdotal, but it was a lot of anecdotal data that there was much worse than this. And what kinds of anecdotes were we hearing? One was from people that worked in the field. They had seen how many houses had been just teared out, but also the main one was people saying that hospitals have no electricity, and they were not, the systems for ambulances and all that stuff was down. It was a disaster. So a lot of people were not, we just couldn't believe this was the case. And if a governor thinks this is only 16 and there's something bad going on, then it's a problem, because it means they're not really going to take action to solve any problem that might be there. So just this is not something statisticians don't need to hear, epidemiologists don't need to hear, but why do we estimate disease and death rates in real time? Because this is how we identify problems and can act on them. This paper is the one that led us to discover there was a problem with HIV. It was monitoring a certain type of disease that led us to not realize that something was going on. It was data driven. It was just observing something out of the audio that wasn't usual, and that led to, I hope you all know the story of that, how eventually we were able to accept that there was a problem and start acting on it. So in Puerto Rico, there's we have to know if something's going wrong, and this is related to deaths right now. We have to define unusual. That's the word that's used all over the place when you're talking about disease outbreaks or excess deaths. So what should we expect? So in September 2012, this is just an example. This is how many people died in Puerto Rico, 2,451. And this is 87 more people than the previous year in September 2011. So do we worry about that? Right, so that's in 2012. In December, not 2,604 died. That's 158 more than in September. So should we worry about that? What's unusual? So what this is how statistics gets involved here, because unusual or usual is not a number. So that's why that conversation we just had was really not very productive. Usual is not a number, but a distribution. So this is an approximation of the distribution for Septembers in Puerto Rico. You can see the range. And then that's using data from 2010 to 2016. You can estimate the expected value and the standard deviation. So if you assume it's a normal distribution, which it is sort of, it's pretty close, then it means that usual years will be between 2,150 and 2,650 in September. So now we can look at the actual result and see if there's something unusual happening. That's September. So I'm talking about September because that's when Maria hit. So here's January. So January or December is the same. It's different, and that's because of the flu. This is common almost everywhere. That in the winter years, in the winter months, there's more deaths, mainly because of flu season. So you can see that in January the distribution is different. So now, should we be looking at totals? I'm showing totals because there was a lot of the talk at the time was about, look, everybody was saying there's these many total, this many numbers, and that's actually not what we do in epidemiology and biostatistics. We look at rates. I'm going to go quickly through this because it should be obvious to some of you that what we should be looking at is rates. So the example I'm showing here is that in 2011, more people died in Puerto Rico a lot more than in 2016, but then a lot of people left. This is something else that you might not know about Puerto Rico. Is one of the few countries that has a decreasing population, and it's decreasing quite a bit. Almost, I think we're at 20% from the peak now. So the rate actually went up. Oops, sorry. The numbers went down, but the rates went up because there's less people. Other complication in Puerto Rico is that not only are people leaving, but they are leaving. The demographics of the people who are leaving are not uniform. So what this little animation shows you is a population change through the years, and what you can see here, if you look at the purple and the red, those are the older older people, their percentages are increasing. So the population is decreasing, and the population is getting a lot older. I mean, for those of you who know demography, you will see that this is quite this is quite unusual to see this humongous change in the distribution of ages in the country, in a place. And the right is United States as a control group, so you can see the big difference. Okay, so back to October 2017 when this statement was made. So if we look at, if we define excess deaths now as the current death rate, sorry, not rata rate, minus the expected death rate, then we can see if that's outside the usual range. And then we can actually, if we want to compute excess deaths, which people seem to always want to hear, then you can take the observed deaths minus the expected death rate times the population size. And then we can see if that's outside the usual range. 16 is not outside the normal range for September, but the question now is, do we believe the 16? So at that time, when that number was being shown by the government, there was no way to get data for official data of how many people had died. And I can tell you more about that story, but we were trying to get it and couldn't get it. This is now when I say we, is a team at Harvard, that because this number was being thrown around and the government's official number was continued to be low. They kept it low for months. It just seemed, a lot of people thought it was important to send a message that that's not what's happening. There's a public health crisis there, and there's more people dying than there should be. Something has to be done. The government's saying no, it isn't. It's not a problem. So when this was all happening, I got a visit from Caroline Bucky, who was listed at the beginning of the talk, and she thought we should try to estimate it without the government's official numbers by doing a survey. Now that's something that's not usually done in places where death data is collected, because if your death data is collected, you can just look at that. It's usually done in places that have very bad infrastructure and don't keep those numbers, but that's what we thought we had to do. So they organized a survey. We sent people with iPads out up in the mountains, and they would go to houses and ask people, has anybody died here? So that was the strategy. So then that way you get an estimate of the death rate that way. Of course, when you sample this way, when you do a sample like this, there's a lot of variability just from the sample. We visited 3,000 households for about 10,000 people, which is actually not a big number when you're estimating a small rate. And statisticians, you guys can do the math for that one. It's not hard. While we were doing all this, somehow some groups were able to get we're still not completely sure how it happened that they got it and we couldn't, but some groups were actually getting data from the government's official registry. Now after some years, I kind of have an idea how this all happens. You have to find the right person to get it. It's like what do you guys call it? A jeitinho. It's kind of like, it's a little bit like that. But anyways, some people had access to it, and they estimated the number to be 518 and 567 in September, October, much higher than the 60. And then we got the data from that by archive paper, and you could see it. There's the data they had. These are the blue are 2017, and you can see that the two dates in 2017 were much higher than the previous 10 years, which are shown here as the averages in black, and the range is shown in gray. These are the death rates. So the New York Times also got access to that somehow, and they also said it's about 1,000. This is in December, I think, when this comes out, December 9th. So at that point, we thought, well, maybe we don't have to do our survey. There's this academic groups, New York Times, they're saying it's not at this time, the government had it up to 64. New York Times, some academic groups were saying it was up in the 1,000. Well, then, even with all this is what the Secretary of the Department of Public Safety says. Says he's not concerned. And then in red, I want you to read that what's in red, because this is what really concerned us. It says it should be noted that similar numbers are seen in December and January of previous years. So he's comparing September to January. He's saying, oh, this is not a big number. We've seen that in December and January. But this is comparing apples to oranges. As we saw earlier, December has higher numbers just because of the way things are. If you compute these numbers by month, you would see that in September you get 514 extra deaths, and in January you also get a high number, 229. So at that point we continued, because of mainly because of the statement made, the fact that they were ignoring these other results, we decided to just keep going with our study. And we did it. It got published in the New England Journal of Medicine. This is the screenshot. You can see the page views just a couple of days after it. The reason it had so many page views is because it got the news media got a hold of this. So let me show you, before I tell you a little bit of a story about the news media and another topic of interest to statisticians. This is what the data was. It was only 10,000 people, so there's not that many deaths. But here's what we go to households and ask people how many people died. This is the age. This is the age of the person that died, of the people that said yes, somebody died here, and then the day of the year when they died. So this is before the hurricane, and this is after. And again, this is from the survey. So you can, just from that figure, you can see that we're going to come up with a big number. Right? There's a lot. The rate on the right is much higher than the rate on the left. So it was a very It's a very unprecise estimate because it's based on a small sample size, relatively speaking. So I was actually very concerned when we were publishing this paper about people misinterpreting these results, because we got a number up around 4,000. And I was, this is now, I'm changing topics a little bit just because I think it's an interesting story for statisticians that you have to communicate with the public. So when we're getting ready to put the paper out, the university is going to put out a press release, which I'm not a fan of press releases, but they do it. And I was concerned that they were not going to report the uncertainty appropriately. And so I kept emailing them and saying, make sure the confidence intervals are reported for every estimate. And then I edited what they had sent and sent them back. But I remember saying, I didn't write this in the email, but I said, what we don't want is an article saying Harvard professor says 4,000 people have died in Puerto Rico. That's what I don't want to happen, but that's exactly what happened. So this is a headline from the Boston Globe, and then you saw that our own public health, our own PR team puts out the number without the confidence intervals, which I corrected right away. This is the confidence interval. You can see how imprecise it was. And then, people just started repeating that number like crazy. Here's another one from CNN. Now, so anyways, that was the I don't know. We can discuss that more if you're interested, but I've learned some lessons from that experience. All right, well, the good news is that the big number that was being reported did put pressure on the government. And one of the things that came out of it was, this is a very interesting interview. You can watch it on YouTube, where Anderson Cooper, he's not actually talking about the number. He's actually talking about why we didn't get data, because they were saying people in the government said you shouldn't do a survey like that to estimate this. It's not the right way to do it, which, it's true. It's not the best way to do it, but we had no other options that we can think of. In this interview, he's asking about that. Like, then how come they didn't have the data they needed to do it right? And he's harping on it. And then if you look at what the governor says, he said they were saying that the data was always available. And he doesn't know why we're saying that. We have the email where we're denied the data, so we can show that to anybody who wants to see it. And then right after that, they they released the data, and it was pretty clear right away that there was more deaths, and they were reporting. Now, once I have after this happened, I got all the data. I wasn't getting much. It was like more than I wanted. Like they had daily data. They had actually it's data by individual without the names, of course. But anyways, I could make a plot like this. This is just the number of deaths per day. The black line is just the lowest line going through it, just as an exploration tool. This is 2015. You can see what it looks like. There's more deaths in the winter. This is December 16. You can see it's pretty, it's pretty consistent. But now 2017, it's consistent again up until September, when you see many more than 16 deaths. Obviously, you don't even have to do a statistical analysis here. It was clear that that there was something going on. All you have to do is plot it. So then when we did fit a statistical method, we're actually writing that paper now. It's an alternative way to how the CDC does it, because it helps you see these things a little better. And we found that there was a long period of excess deaths. This is April. It's like 5-6 months of excess deaths. That's an estimate of the increase in death rate that we get from our model. So after all this, we started giving talks and publishing reports on this, and now the media now is saying that we actually got it, that we were now correcting our previous number. So it doesn't matter how many times I talked about confidence intervals. It's just like doesn't matter. Okay, so that's the introduction. Let me come back here. Sorry, I'll be right over. So I want to now talk about our experience with COVID, with the COVID pandemic. It relates a little bit to this, because it just shows you like the problems that we have with getting data. Now the same storyline you're gonna hear again now. Okay, so let me share this. Or is it? This is it. No, not that one. Sorry. I'll be right here. I'll be right over. This one. This is the one I want. I'm sorry. Come on. Okay. Where are you? Sorry, I'm trying to find the thing. How come it doesn't show up here? Ah, here it is. Okay. Okay, can you see that?
Yes, it's perfect.
Okay, I'll make it a little bigger. All right, so this is I just made this. This was made in our Markdown, so all the analysis just happened a few hours ago, or minutes ago in some cases. So I apologize if there's any typos or small mistakes. Okay, so now this is March 11 this year, and when this all when we start seeing that this is a big problem, and we see it in Spain and Italy, we're in China, we're seeing a lot of cases and deaths. Knowing what had happened with Maria, I'm pretty freaked out about what might happen in Puerto Rico. So by the way, I'm going to be showing tweets, because I didn't want to make the figures again. I'm just getting them from what I put on Twitter. I hope you're okay with that. So here's the first tweet I had about this concern. In particular, there's a combination of as far as I could tell, lack of organization of data, and the fact that there's so many old people in Puerto Rico. Here's a distribution of age, which I already showed you. On the top, those are at the time, the death rate estimates by age for COVID. So it was mostly affecting people over 60, which Puerto Rico had almost 1 million of them out of 3 million, almost a third of the population, a little bit less, but close, are over 60. So then, but that one piece of good news is that the governor, this is a different governor. That governor got ousted by protest. You can look that up if you want to see an interesting story. The previous one, the new governor issued a lockdown very quickly, which was I thought it was great. It was before, I think, any other state in the United States. Puerto Rico is not a state, but it's kind of like a state. It's another thing we can talk about. I'll be calling it a country and a state during this talk, if you don't mind. All right, so so that was good. But then this is an article that comes out saying that between 16,000 and 58,000 people were going to die in Puerto Rico. So just to give you an idea how much that is, 58,000 is 2% of the population. So if you have like 1,000 friends, that's 20 of them are going to die, according to this. So when this comes out, I start getting calls from reporters interested in knowing what I think of this estimate, if this is actually going to happen or not. And notice the date is March 25. This is after the lockdown. Okay, so when they asked me about if I can predict, what's my prediction is what they were asking me. One of the things I had to explain is that I don't do mathematical models. So how could you make that prediction? At that time there was, I think, 2 deaths in Puerto Rico and maybe a few dozen cases. So those calculations are made with mathematical models. So if you've been following the COVID pandemic, especially during the first days, a lot of those predictions, they weren't built on statistical models. It was like a differential equation approach to trying to predict how nature works and come up with estimates that way. Not estimates, predictions. There's no data, so there's no estimates. It's just generating simulations from a mathematical model. So I don't have to explain this to you, but in statistics we don't really do that. Instead we adjust models to observe data, and we limit to few models. We're limited to a few models. We don't like try to build one every time. So we have a toolbox of things we pick from. So I was trying to explain that this distinction, it's not an easy thing to explain to the press or to people in general, but we're trying. But then the other point I was making is that in this case, I with so few data, what I was thinking we should do is just plot the data every day, just have it very updated, and we can follow along and look for patterns just by looking at it without having to rely necessarily on fitting models that might be wrong or might be underestimating uncertainty. So that was what I was saying at the time, and I was showing people how hard it is to predict. So this is Italy and Spain, March 9. Those are the deaths. So if I show you this and I ask you, what do you say? Predict what's going to happen. And you can see, if you don't see it, there's some deaths in Spain here. What's going to happen the next 2 weeks? Could you tell? Well, here's what happened the next 2 weeks. It started growing exponentially. But now if I ask you to tell me what happened next, like, does it keep going to 10,000 or 100,000? Well, that's not what happened. It started going down. But again, how do we predict all this from these mathematical models? I don't think this is what comes out. But you can actually get data and look at it. So that's what I'm going to be trying to convince you of today. So here's New York, and here's more examples. Here's New York and Massachusetts, and now it's up to March 25. Remember, it came to the U.S. a little bit later than it came to Italy and Spain. This is when I get contacted by reporters when the article came out around March 25th. This is what I was trying to show them. Look how different the outcomes can be. So here's what's happening in Massachusetts and New York. Like if you go back to when there was nothing going on, I mean, I don't know how you can predict that New York was going to have so many more than Massachusetts. Here's Puerto Rico and Brazil. I included Brazil here, and now I changed the y-axis. Notice how I changed it from 800 to 15. 15. There was in Puerto Rico there was 2 deaths at that time. Cases were also very few. I had no way of predicting anything, so that was my answer. I have no idea. Same in Brazil. There were very, very few deaths and cases at that time. So at that time, just to show you what some people were trying to do and just to show you how hard it is, these are 2 quotes. The first one is from a famous baseball player. The second one is from a statistician or epidemiologist. And she made this nice simulation, which shows you. So what's what it's showing you is how do you predict the S-curve to look if you have just data up until here. So that's the blue. The blue is the data you have. The black is the truth that she constructed from the simulation, and the red is the best estimate you get when you just have this much data. Right? So you're going to see what's going on with that curve. It's low, and then it jumps, and it's all over the place. Right? So you can see that you need quite a bit of data to get to something to stabilize. So I my view was, let's just keep looking at this part and don't try to come up with this part necessarily. I mean, just looking at this is already providing you enough information to take action. Okay, go ahead, move over. Okay, so here's what's ended up happening in New York and Massachusetts. New York has more people, but it still doesn't explain that much of a bigger peak. In New York, I think it's 50% of the deaths were in retirement homes, which was what made it so bad. But the other thing you see here is that now it's gone down dramatically. Okay, so what can we do? So now I'm going to talk about what to do to monitor it and to make decisions to keep it from getting worse. So we already know transmission is high, so I don't even know if we need to estimate this RT thing that people like estimating, the rate of growth. So we already know it's high. The lockdowns make it slower. So I think that once you know those two things, and I think what we really want to be estimating as best as possible is the number of infected individuals. That's very hard to estimate, but we can get ideas at least of the patterns, not necessarily the exact number, but at least if it's going up or down. And one of the points I have to make is that the number of reported cases is actually not a good estimate, and I'll show you why. So here's the data from Puerto Rico from when this was when I was trying to convince the government to make data public and let us look at it. So they were actually reporting cases. These are the cases. I'll tell you what, this isn't necessarily that useful. These are just cases, but we don't know how many tests they're doing. So here is the problem with that. Here's the number of cases per day. This is the average number. Oh, this is the average number of cases per day of the week. You see the problem? It's impossible. The virus does not take weekends off, so that those two low values, Sunday, Saturday, can't be right. That's because they're doing less tests on those days, and it's fine. That's, people have to take weekends off sometimes. Also, there's other reasons for it, like the testing sites get their reagents every Monday, so they start running out towards the end of the week. Yeah. So here's another example. This is the number of cases in the U.S. and this just doesn't match what we see with deaths. The deaths were way higher in March, but all of a sudden there's this huge peak in July, and that's because there's a lot more tests now. That's the truth. So, but there is still a second peak. You can see it here. This is now what we call the positivity rate. That's what we're going to try to get to convince you that that's one of the main things we should be looking at. Positivity rate is the number of people that test positive from the people who took the test. So it takes into account that there's more tests. So you can see that now it's not like it went way up, but it did go up. Now I should point out that's not the case in every state in the U.S. Just so you know, you're aware that U.S. is just like Brazil, is a big country with many states, and they're all very different. New York and Massachusetts have gotten their positivity rate way below the 5% that we think should be we should be definitely being under. Okay, so what is it? So the positivity rate, what we're trying to do, although it's definitely not what we actually end up doing. We're trying to estimate prevalence. So again, you're statisticians, so you know what this is. The prevalence is the percent of reds among the population here. We want to know that, but we can't test everybody, so we try to estimate it from the people we test. Now, a problem at the beginning, when you have low test, when you have few number of tests, is that they tend to prioritize symptomatic people, so you're going to end up with a pretty biased estimate. Quite biased, because you're going to people who you think have it, so of course you're going to get more. But as the testing became more available, they started widening out, making it more universal, and then those become less biased. Still biased, because it's still people who think they have it mostly that take the test, at least here. But the other thing to know is that even if you're doing somewhat universal testing, the more you test, the more cases you will see. So you can't, and the opposite is also true. you can't think all of a sudden things are getting better, and it turns out that it's just because we're doing less tests. So it's important to get that rate. So in problem in Puerto Rico, this is all through up until June. We were trying to get the number of tests. We couldn't get it. So we actually don't know what's going on. So the Massachusetts dashboard, just to point this out, Massachusetts actually, I think, did pretty well during this whole thing. They had a high peak, but they controlled it quickly, and now we're pretty, it's pretty open. They have this dashboard they have is pretty nice. And the first thing they look at is positivity rate. That's that first curve in aqua, and there it is. This is at July 13. This is an old screenshot. But you can see it's at 1%, and the numbers that are being shared about, like the experts saying you should have it under 5. If you're over 5, you should lock down. So actually, I think that's the WHO that says that you have to have 14 days under 5 to open. That's the recommendation. So you can see Massachusetts has been under 5 for quite a while. They have other things there too, which is also very informative. So Puerto Rico didn't have that. And when you looked at dashboards that aggregate data from different states and countries, you would see ridiculous things coming out of Puerto Rico. Like, this is an estimate of the positivity rate by state. Puerto Rico supposedly had 100% positivity rate. So everybody had it according to this. That's not Johns Hopkins' fault. That's because the government wasn't providing the right information. They weren't providing the number of tests. They were just providing the cases. So I think somehow those two columns became the same. So here's another crazy one. This is like the positivity rate is in blue, and you can see it jumping from 0 to 100, like one day to the next. Obviously, the data was not quality. It wasn't useful. Here's another one. You can see it's 100%. So during that time when we didn't know, I couldn't really use that to monitor anything. One of the things that I was doing is using what we had learned from excess deaths analysis to be checking if something was going on. This is April, May, June, and now we actually, maybe in part because of Maria, the people in the demographic registry, they're super collaborative, and they send us the data and they answer all our questions. It's been really great working with them. And so they send us the data every week, and every week we'd make a plot to check if something was going on, because the COVID data wasn't really that great. So this is now excess deaths, nothing to do with COVID. It's just excess deaths. If in fact the excess deaths are growing, we're gonna suspect it's because of COVID. So actually this analysis was something that the New York Times asked me to do for them. You can look at this paper and see some of the nice plots that they included here. We did it for the US with data from the census. We computed excess deaths. But in the US, the excess deaths were higher than what the COVID numbers were, but they weren't that much higher. I think it ended up being like 20 to 40%. I can't remember the exact number. But you could see that there was a high correlation between the states where we calculated high excess deaths with the state that were reporting high COVID numbers, very high correlation. So even though there was an undercount, it wasn't massive. So in Puerto Rico, there was some concerns because at some point, the data starts coming out, and there were a lot more deaths in March 2020 compared to 2019. But like I said earlier, this is a little bit tricky because of all the things that are happening. Like, there's more old people, there's less people. It's not clear that we can compare these numbers directly. And the other challenge was that the data was incomplete. So we had to either figure out ways to adjust for that. So this is the data up until July 15, I think. It's incomplete, and that's normal. It's always incomplete at the end because all the information isn't in yet. So it takes them about 45 days to complete this data. But anyways, the problem, as I said earlier, problem in Puerto Rico is if you look at just deaths per year, you see this weird pattern of deaths growing and then straight. The growth is because the population was growing, and the straight is because the population started decreasing, but the old people also started increasing, so they kind of canceled out. So this is the actual death rate for 60-year-olds. That's the adjusting for all these things. And you can see that it's actually going down. This is the year of Maria, where it went way up. And then the March days are kind of all over the place. So it's really not, comparing these 2 years isn't really necessarily something we would be doing. So we were using deaths, and we really didn't see much room, not much concern with that, with just the excess deaths in Puerto Rico around June. There was a bit of an excess, about 100 excess deaths of 100 for older people in March and April, but that was it. So there didn't seem to be underreporting of COVID information necessarily. But this could change rapidly. And how will we know if it does? So just to show you, in Puerto Rico, some of the things we learned with the Western Maria, with some of the data, is that there's been some instances where excess deaths have grown, and nobody has, at least I don't know of anybody reported it at the time. So this is what a normal year looks like. The points are weekly deaths. I think these are normal years, 2011, 2012, and the blue line is the curve that our model predicts. That's how many deaths we predict for that day, and you can see that it's pretty. It looks like there's no excess. But if you look at Maria, obviously there's a huge increase. You can see those red points all above the blue line. And here's Georges. This is a hurricane that happened in 1998. And I don't remember anybody talking about excess deaths back then, but you can see there's about 1,000 if I count right, maybe a bit more. And the other one is in COVID, we really don't see much. There's a little bit of an excess death there in March and April, but not like the other ones. And here's chikungunya, which was, again, I didn't hear any reports. This is like 1,000 extra deaths that I'm seeing here. So I'm worried that if something does happen, we will have no idea because nobody's really monitoring. So I start talking about it, that we need data, we need reliable data. This is in Spanish, maybe you can probably read it, but I'm saying I don't trust the data that the health department's giving out, in part because there's no test data. And I'm saying, look, if we didn't catch those other things, are we going to catch this one? So these public statements led to collaborations. People contacted me. In particular, this one organization, it's called the Puerto Rico Science Trust. The Puerto Rico Public Health Trust is part of that. They contacted me and said, we have data from the private clinical labs, not the government. They had it straight from the clinical lab. So most of these tests are done by private companies. And they had these Excel sheets. This was a pretty interesting wrangling problem, getting all that into a form I could make a plot, but that's another story. And you can see here that once we got that data, it looked like, okay, now we can feel a little better. The blue is Puerto Rico, but this is June. This is the middle of June. Right? So you can see that the positivity rate is in fact quite low. However, if you look closely at that last little one, there's a little bit of an uptick, but that could be statistical variation. We'll say more about that later. But I say, okay, things are good. It's below 1. That's good. But you can see it at the bottom. I'm saying even if it's low, it could go up real quick. So this is, by the way, this is weekly data. They meet the clinical labs every week. So by the time you get this data, it's already a week has gone by. If something went up, you're going to be a week late in acting. So I was hoping that we would get daily data, every day, daily data, and be able to monitor it. So I was saying is, listen, all we need is a table. We don't need anything fancy. This is what Massachusetts gives. There's the table down here. Just a table. Just give me the numbers and we'll be able to monitor. If you give me the table every day, we can monitor it. So then I'm saying, then I get data again from that group, from the Puerto Rico Science Trust. This is not the government yet. And then now we're seeing an uptick. So this is now at the end of June, and you can see, so this is the one we had seen before. There's a little bit of an uptick, still under 1, but now we see 1, and now I'm definitely concerned. So we also got hospitalization data, and it was going up too. So we keep tweeting about it to see if we get some information. This data, by the way, we had to scrape it from a JPEG. That's fun. There's tools for doing that actually, so it's not that bad. So now, finally, we get connected with the health department and we find the person that we needed to talk to. This happened through the Puerto Rico Public Health Trust. They connected us to the person that was just hired to build a database that was automatic and all this. And these kids, I call them kids, these professionals they're much younger than me, so that's why I call them kids. But they're professional. They're really professional, very competent people they got hired, which I was very impressed, to build a database. And they they start sending me examples of what the data looks like. And more than that, I'm not saying it yet, but they're actually building an API so I can get the data without bothering them. It's great. This is like the best case scenario. And finally, we start collaborating with the health department, the official government, right on time. Because right when they start sending us data, we see that positivity rate went above 5%, which is when the alarm bells go off. So, and by the way, I'll say that the first data set we got from them when we were testing it out, we could already see that there was a little bit of an uptick coming right there. You see how it's straight. By the way, it was gone in Puerto Rico. There was no COVID, pretty much gone. I shouldn't say gone, pretty much gone. And then it starts again. And what we're saying is that, oh, did I say that wrong? I might have said something wrong. No, I said hospitalization. This is Florida. So when we show this, when it starts going up here, we also show the fact that in Florida, starting in June, there was a big outbreak. And there's 27 flights that come from Florida to Puerto Rico every day. So we're basically warning, this could come here just like Florida, could happen. So that was a warning at that point. So then they share they not only share data, they now share an API. It means that we can actually build a tool that automatically updates all that stuff. And now we build this I'll show it to you in a second. But we're able to build this dashboard where it automatically gets updated. Now, once we do that, we start seeing that it's every day. People can go, reporters start looking at it, and then people are talking about it's going up, positivity rate's going up. There's the website. I'll show it to you in a second. And then we see our plus show up in a press conference from the governor, and that day they closed down again. So that was, in a way, a good ending to the story, at least somewhat good. So we have, I'll show you what it looks like. This is what we built. All the code is on GitHub. You can see it. So here's the plot. It gets updated every hour. So there's the APIs here, and all the GitHub code is here. It's a Shiny app, and it you can change it however you want. And the key thing about it is that it updates every hour. So this is what it is. We're very high now at 15. It does look like it's plateauing. We have hospitalizations. This would be the limit of beds. So we show that, but you can change it so you can see a close-up. It looks like it's maybe plateauing, but maybe not. ICU cases, again, that doesn't look like necessarily a plateau. We have deaths. Anyways, now it's basically turning and these are the tests, these are the positives, etc. Oh, but we have it by Puerto Rico, believe it or not, has 78 towns. So these are all of them, and there's a little map showing you what the positivity rate is by town. If you look at the last 2 weeks, you see it gets much worse. Okay, so I thought that was great that they made an API and they talked to us, so they helped us build this. So here's what's happening now. Here's Brazil. You guys aren't doing great. Puerto Rico is not that bad. This is the number of deaths, 10. So notice the scales are different. Of course, there's 100 times more people in Brazil than Puerto Rico, I think. But that's where we are now. We're trying to keep things under control, and we hope that it works out. It does seem like it plateaued a little bit, and I'm hoping that it was the fact that they closed when they saw the positivity rate go up It means that they did the right thing. So here's some recommendations. Number one, this was the, by the way, making that dashboard, it took me, I think, maybe a total of 3 hours. The hard part was getting the database going, and that wasn't me at all. These were these people at the Department of Health who did it. They organized the data. They went from whatever they were doing before, which I think was just keeping Excel sheets, to actually having a database. I don't know all the details about that. I hope to meet them one day and talk about it. But then also, visualization is already a very powerful tool. You don't necessarily have to be fitting models and making predictions. Just looking at the data as updated as possible, can take you a long way. We do it by geographical regions. This is an infectious disease, so there might be outbreaks in some parts and not others. And if you're interested, all the code for everything we've done is on GitHub, including, I'll put this talk up there as well, which is our markdown. So here are some of the people that helped. Rolando's working with me on the excess death estimates. These two are there's others, but they're part of the team in the Department of Health. They've been great. And then the demographic registry that has also been great at sending us data. And then the people at the Puerto Rico Science Trust who made all the connections for us, and Danielle, who's in Yale, has also helped us make these connections. And then finally, the people that educate me about COVID are Caroline, Michael, Mark, and Natalie. Okay, and I'm going to stop there.
Perfect, Rafa. Thank you very much. People are getting very excited about your talk. I can highlight Professor Giannato from Wisconsin, who is congratulating you for the Spanglish slides.
Oh, yeah. Sorry about that.
No, this is good fun. We usually take questions from the chat, and then I start forwarding them to you. And the first one came from Juliana.
Okay.
Oops, hold on. Here. She's saying, I've had that an informal way to have an idea about the number of infected people is to trace the people that travels outside a particular place, in this case, Puerto Rico. Do you have access to this information?
I don't, but it's there. Somebody has it, so they're doing that now. I'm not involved, but I hear about it. That there are efforts now in Puerto Rico to do what's called contact tracing. It's a very important thing to do. Massachusetts is doing it as well, and the idea is that, yeah, you go. I don't know if this is the question I was asked, but as soon as someone has a case, you go and ask them who they've been in contact with, and then you call those people, and you keep going like that. So in the case of Puerto Rico, there have been anecdotal reports that several of the big outbreaks were people who went, either people who came to visit their moms or grandmothers, or people who went to the US for whatever reason and then came back, especially to Florida, but other places too. So that they have figured that out from the contact tracing. I don't have that information. It's not part of what's shared in the API. They might share with me at some point, although I don't think they necessarily need me for that. There's a very competent group of people that can do that already. But yeah, that's definitely something that should be done, is keep track of people. In Massachusetts, if you travel and when you come back, you have to quarantine for 14 days or get a test.
Okay.
I don't know if I answered the question.
Well, we'll have to wait for feedback from her.
Okay.
In the meantime, Lorena Barberia is asking, thank you, first of all, for the excellent presentation. This is fantastic, and it echoes many challenges that we have here in Brazil on data and interactions with policymakers. Mm-hmm. Can you talk a little bit about the testing capacity in terms of labs in Puerto Rico? Yeah. And how quickly are the tests being collected and reported? Yeah,
that's a good one. That's very, it's a topic of current conversation in Puerto Rico. So let me show you, I can go here. Let me show you this. Here we go. Let me put it back. Oops. All right, so here, these are the tests day by day in Puerto Rico, and then the step line is weekly, because there's a huge weekend effect. I don't know if you can see it. You can clearly see the weekends. So I also include a weekly average to avoid that artifact. So we're doing in Puerto Rico, they're doing, you can see what happened at the beginning. In the US, there was a mess at the beginning. It's a whole story about the CDC not letting people do their own tests and taking a while to give permission. It was a disaster. Eventually, they did the right thing and let the private labs do what they do best. Now, the labs that do these kinds of things are mostly private. There's I mean, I don't want to do free advertising, but there's a couple of really famous companies that do this. So once that gets going, then in Puerto Rico they have a lot of private labs that know how to do this. They know how to get their test. They know how to buy tests. They know. So once the big companies are selling these tests, it just starts flowing, and you can see what happened. I mean, the number went way up. Yeah, you see that? So at the beginning, there was confusion everywhere. They were saying, oh, we can't get him, but then eventually, and I hear also some stories that this is also the doing of the Puerto Rico Science Trust, that they connected some of the private labs with the companies that were offering them, and they connected them they were making connections so that people could talk to each other. But again, all this is mostly private companies doing it, private labs. Now you see this dip at here. That dip is because they're running out of reagents, is what we're told. I mean, I'm getting this from the news. I don't know if it's not direct knowledge, but there's a shortfall of some of the reagents, so they're not running as many tests right now. Now, so that's always it's always an interesting story that's going on in the background with this stuff. In terms of how fast does it get into the database, that has been getting better. The people who run this database are getting better and better at it. They're making it easier for the private labs to put their data sets in. So I've been noticing, because I look at this thing every day, I've been noticing that that now by day 3, it's mostly complete, not completely complete, but mostly complete. And at the beginning, it took about a week or more. So that's a great question. I don't know actually the details of the answer, but it is an important thing to figure out. It's not easy. It's not straightforward, and there's a lot of things you can do to make things better. So I mean, I won't comment about what I don't know, but I can tell you there's a lot of things going on in the background that affect the number of tests that are being run. So this 5,000 a day is pretty good. Puerto Rico has 3 million people, so that's pretty good. I wish they could stay at that level. They might get back there again soon. So that's so it's possible, it's doable, and it might be even get better as new ideas are lead to easier tests and cheaper tests. And by the way, these are all, I should have said, these are all molecular tests, not the serological ones. I have the serological data too, but that's a different story. I didn't want to complicate things. But yeah, these tests are expensive, by the way, and hard to do. They want to stick the thing up your nose. Yeah. So they should become easier to do and cheaper, and then we'll be able to have even more.
And do you have an idea of how much time it takes between getting tested and getting the
2 days, I think, in Puerto Rico. The median is, according to the database, is about 2 to 3 days. Is how it's a median. I know that it can be done in hours. I know that technically it's possible to do in hours, and I think in some countries they have it down to an hour. Iceland, I think, has it down to like a few hours. You go in, and 8 hours later, you know.
Mm-hmm.
But there's depending how organized you are, the logistics, it ends up taking, median is about 2 to 3 days in at least in Puerto Rico.
I see. And a follow-up question from Lorena is: are you able to correct for repeated tests? Do you have this sort of level of data that you know that a particular test came from person A?
I had it for 1 day. It's funny that you asked me that now. I just went through this. For 1 day I had it. This data is not. This is why I say tests everywhere. I don't say cases. You won't find cases anywhere on this dashboard because I don't know the cases. I can't know them because I would need to know, I would need to have an ID. So for one day, I had it. So the database people were able to add, they were able to add an ID that was HIPAA compliant. That's how good they are. They know how to do that. That's like, these are serious people that were running this thing. But then when I got it, and then I changed the AP, I changed the dashboard. I worked like 2 hours on it. I changed it all. I put it up, and then when I put it up, my cases were different from the Department of Health numbers. And then apparently they started talking about this, and they thought that they weren't completely removing I had more than they did. So they thought that the database was missing some duplicates. I don't know how that could happen. I guess maybe a person has the same name but adds a Beneltin instead of Benelton.
Yeah.
And all of a sudden you're there. Oh, you fixed it. All of a sudden there's two people when there was really one. You see what I mean? So I don't know. Yes. But the answer to that question is that I for one day I had a column that had ID, and then I can compute cases instead of just positive tests. There's about, I think it's about 10% is what it reduces, about 10% is what I saw when you take out the duplicates.
Okay.
And one more thing to say, for positivity rate, I'm not too concerned about the duplicates because I'm looking for trends. And whatever biases those things introduce, I don't think it's going to affect the trend. I haven't thought of a way that it could, right? So I more than anything, I'm looking for this is going up. Now it's kind of leveling off. Good. I hope it keeps. I hope it starts coming down. But that's more what I'm looking for.
I see. And are you aware of any type of variation in terms of positivity rate in public and private labs?
Yeah.
Do you have data stratified by type of lab, by the way?
Yeah, I do. I have it. I have it, and there is a little bit of a difference. Some of the labs are more geared towards people who are coming into hospitals, or are being traced, right? So that they're more likely to have it. But I think I don't think it's because of problems with the testing. I think it's just the populations are different. So see what I'm saying? Like if you have a clinical lab that just is open to anybody, that they're going to have a lower positivity rate than one that's just looking at cases that were traced.
Yeah, true. And is it mandatory for both public and private labs to report all tests regardless positiveness?
I think it is. Yeah, I think it is. My understanding is that they have to report it by law to the government, at least in Puerto Rico, and I think in the U.S. too. There's all these laws about having to report things to the state, and then eventually the state has to report it to the CDC. So let me say something about the U.S. The census and the CDC, they have really great procedures and rules to collect data and organize it. They are very good at it. They have APIs too. The CDC has a great API where you can get all kinds of data straight from R. Something if you want to look to somebody to improving how you're doing things in your state, you might actually look at how they do it in all the rules and procedures they have in the CDC and census. They are very advanced, and it doesn't matter who the president is. That like the president can change the leader, but all the other people working there, they don't leave, right? They're just professional. They're like career professionals.
Yeah. And Professor Moritin is actually asking, how do you compute trends on low-S or some other model?
Yeah, good. So you can look at the code if you really want to know, but this that you're seeing here is a spline. And the reason I'm using a spline is because this is like a binomial, right? Because it's the percent that are positive, and I don't want negative confidence intervals, negative values in the confidence interval. So I do a GLM with a binomial, and then the logistic link to a spline that has a not every 2 weeks, I think. That's what this is. So I use a spline instead of OS because one, I want to be able to It's easier to fit with a GLM and get the right confidence intervals. And also because prediction, although I don't know how, so the end here is predicted. I don't use the last points. That's not really a great reason, but that's something. Another thing that splines give you is that you can compute the derivative really quick for any point. You can do that with LOS too, but with the spline, you actually have a formula for it. So yeah, I prefer LOS in general, but for things like this, where I kind of have to use a GLM, I almost have to use a spline. I don't know. I mean, there might be other things you can do like GAM and whatnot, but this is so quick and it's like 2 lines of code. The other thing that this has is a weekday effect, which is kind of important. As you can see, you see these high points. So I think it's a Monday. I can't remember the exact day, but there's one day where I think they turn in all the positives, and then it has a huge rate that day. So I account for that effect. Okay.
You mean like a weekday as a predictor there?
Yeah, it's a covariate. Yeah, just so that it accounts for that variability, and then I don't have I don't let it affect the actual curve. The curve you see does not include the weekday effect. That's left out. I don't include that here because I don't think it's of interest.
Yeah. So you mentioned that the difference between the mathematical models like ODE and the statistical models, and what do you think, or have you looked into combination of both?
No, not me. But yeah, I think that would be the way. If somebody really wanted me to calculate R0 or RT, I would probably want to do something like that. Something that uses as much as possible, uses the data to compute. I've seen people that are starting to look at they take the deaths, hospitalizations, and cases, and from that they try to predict how many actual cases there are. Like, so if you know the deaths and you know that the infection rate, you can kind of get an idea of how many. And once you actually know the actual cases, then computing RT isn't that hard. Yeah. So that's like computing RT is yeah. It's like the ODE give you what the model should be, but you can use the data to make it fit. But when you're starting from nothing, like they were in March, then you have to plug in whatever you think is the right parameters, and then anything can happen, right?
Now, a personal question here. It's out of curiosity, really. I've seen that President Trump has made changes on data access, apparently through CDC, and goes through the office now. Did that action actually change how you guys access data or anything about that? Yeah.
Not really, no. Because what happens is another thing you should know about the U.S. It's not that widely known. The U.S. is 50 countries, really. States have a lot of power here, and every state has its own public health division or department, and they do all these things. They have to do it. I think for most of them by law they have to keep track of all these things, and they're doing it anyway. It doesn't matter what Trump says. So now what happened was I think they said that I think the order was something about certain data sets had to be sent from the state to the White House instead of the CDC. So yes, if you were getting your data through the CDC, then that might have gone away. But no, I don't know anybody who's getting. All these websites like John Hopkins and the COVID tracking project, they're getting data from this dashboard that I made. We're all getting it from the states. We're not getting it from the CDC. So nothing. It didn't affect us at all.
Perfect. Rafa, I don't see any other questions following up here. So in the meantime, I'll thank you very much for having the time to talk to us. Great talk as always.
Thank you.
I was slightly scared you would be trying to shame me somehow.
Yeah, I thought about it. I ran out of time.
All right, good.
And I think the word is embarrassed, not shame.
Okay. I will learn that difference for my English now. But thank you very much for not embarrassing me.
There you go. There you go.
Hope all is well with you guys.
Thanks. Thanks for the invite.
Thank you very much for accepting the invitation. I'm pretty sure a lot of people who enjoyed it very much.
Okay, good. Bye-bye, everybody.
All right. Thank you. Thank you all. By the way, let me just use one short minute here to remind you guys that on August 24th, we are going to have Francesca Dominici here talking about pollution and COVID-19 events as well. So if you guys want to save the date, just do that. And it's going to be at 4 p.m. as well. We have a lot of people here excited to see you, Rafa. And
yeah, same. I'm sorry I can't see like in person, but I only see the names. But oh, I see Samara. Hey, Samara, I see her name.
Yep. And we have Tatiana.
Maybe she's not. Oh yeah.
Moritine.
Oh, hi everybody.
Rafa. Hi, Rafa.
There you go. How you doing?
Good.
Hey. Oh, when this is all over, I have to come down in person.
Yes.
Yes.
Definitely.
All right.
But that's it. Thank
Bye-bye.
you very much. Regards to your girls. Thank you.
Bye-bye.
Bye-bye.